Hello everyone, I am Dr. Nalini Bansal, and in this session, we'll be discussing about the acute cellular rejection. We have discussed about some early graft dysfunctions like PRIs and other things, and we have also discussed the normal liver pathology. Now, we'll be discussing one of the things that is very common in a liver transplant pathology, and that is acute cellular rejection. The outlines of this talk are going to be why this T cell rejection occurs in liver. So when we talk of acute cellular rejection, we are actually talking about the T cell mediated rejection, and that is we are going to discuss why this rejection occurs in the liver. Then how does this rejection occurs in the liver, and why is liver considered as an immunoprivileged organ? So when we'll be discussing more about the antibody mediated rejection, we would learn that liver is considered to be little immunoprivileged and you do not require any induction for a liver transplant. So why is liver considered as an immunoprivileged? That also we'll be understanding. Then we'll be discussing about the clinical details of an ACR, how they present and what is the common derangement of the LFTs which is usually seen. Then finally, we'll come to the histological features of the ACR, and that is what shall be discussed in detail with you. And then we will be coming to the recent BAF classification, that is the rejection activity index, what is RAI and how is it being graded. When we talk of T cell mediated rejection, or previously which was also known as acute cellular rejection, so the thing is going to start when the liver from the donor is put into the recipient's body. So we have cut a portion of the donor and that is being put into the recipient's body. Now, what will happen is, since this recipient is going to be a foreign material for the recipient, this organ of the donor, which is put into the body of the recipient, is actually a foreign thing which is transplanted into his body. So the immune system of the recipient is going to get activated. And in this session, we'll be discussing about the T cell activation, which occurs secondary to the antigen expression, which is present in the transplanted organ. So as soon as this organ is transplanted and immediately after vascular anastomosis is performed, so there is a mixing of the blood, the passing of the blood from the recipient into the donor organ, and this will lead to activation of the recipient's immune cells, that is the T cells of the recipient. Now, once these T cells are activated, they are going to attack the donor liver. Not in all cases, in some of the cases they will get activated, and then they are going to attack the donor liver, resulting in derangement of the liver enzyme. So this is how it is going to happen, and that is why we see T cell activation in the recipient's organ. So what we know is, on completion of the vascular anastomosis, once the vessels are like anastomosed to each other, the recipient blood is going to traverse through the blood vessel of the donor organ. So half of the portion of the liver that is being put into the recipient, now the blood of the recipient is going to pass through this newly transplanted organ of the donor. Now T and B cells are going to get activated by the antigen in the grafted organ, and then they are activated. So once they will pass through this organ, these cells are going to get activated, and then they are going to incite and elicit an immunological response to this body which is transplanted. So once the blood is going to pass through these sinusoids, and we have all have an understanding of the normal liver histology, that the blood flows to these sinusoids, and the blood that is coming into the liver is coming dominantly by the portal vein and also a portion of it by the hepatic artery. Now, since the blood that is coming from the portal vein is bringing all the blood from the intestine, so actually liver is exposed to n number of antigens prior to being transplanted. So now when the blood of the recipient is going to pass through this donor organ, there are some antigens on the donor cells which are going to interacting with the recipient's blood, and then they are going to elicit a T cell mediated response, which is also known as a cellular rejection. So once they will get activated, we will see the influx of these lymphocytes into the donor liver, and they may or may not elicit an inflammatory reaction to the liver. So now we have seen how the T cell mediated rejection occurs in the liver. Now moving on to the next question, why is liver considered as an immunoprivileged organ? So why do we not see so much of a rejection in the case of liver transplanted organ? So it has been shown that ACR, that is acute cell mediated rejection, they occur in around 20 to 25% of the transplanted liver. The clinically relevant ACRs, they are going to occur only in about 20 to 25% of the transplanted organs. So why we see lesser numbers of ACR in cases of liver transplant? It is because that, as I already mentioned, that the liver is containing a dual blood supply, which maintains a sustained low flow within the fenestrated sinusoidal system. So there is a large amount of blood which is continuously flowing through the sinusoids of the liver. So it is accommodating a persistent antigenic exposure without any sensitization. As we know that there are large number of antigens which are coming from the intestine on a daily basis to the liver sinusoids. So liver has become relatively immune to those antigens because it is exposed to n number of antigens. Then next is the liver parenchyma. We know is actually made up of only the liver cells. So largely 80% of the liver volume is composed of the hepatocytes. Now we know that since majority of the liver parenchyma is made up of liver cells, and all the liver cells, they have an exposure surface towards the sinusoids. So these liver parenchyma has got increased endothelial surface. There is a large amount of surface area with which they are interacting with the sinusoids, and they're also interacting with the antibodies that is passing through the body. There is a lower expression of liver-related class 1 and class 2 HLA antibodies than other organs. So as opposed to other organs, the expression of HLAs are relatively less in the liver, especially of HLA1 type. The endothelial lining, the Kupffer cells, endothelial cells, they regulate the immune responses and so potentially building resistance to antibody-mediated rejection through the attachment with the clearance of circulating HLA class 1 molecules and alloantibodies immune complex. Now, we also know that we have discussed about the liver sinusoids. So we know within the sinusoids, there are large number of these Kupffer cells which are present. So all the blood that is flowing through the liver, there is an expression of these newer antigens which are coming every day, and they are interacting with the sinusoidal cells. And one of the sinusoidal cells are these Kupffer cells which are present in the SOD or the space of Dissay. And these Kupffer cells are basically nullifying all the antigens which are coming through the intestine. So that's why we see there is, because the liver is exposed to large number of antigens every day, so liver has become relatively resistant to the newer exposed antigen because it has a memory of some of these antigens prior to it. So that's why we call liver as an immunoprivileged organ, and that's why we do not see an induction therapy being given for liver transplant, which we usually see for the kidney recipients. So now we have understood why the liver is undergoing a T cell rejection. Now moving on to once a liver is transplanted, so how a clinician will get to know that there is some problem which is occurring in the liver. So the most common clinical presentation that is going to happen. So normally ACR is going to happen a month to 6 months, generally in the 6 months window period post-transplant, though there are cases where they can occur more than 6 months post-transplant. And about the late mediated rejection, we shall be discussing more in more detail in the later classes. So we'll be focusing ourselves mainly to the acute cellular rejection part. Clinically, these patients may present, they could be completely asymptomatic, and on a routine LFT checkup, they are found to have these transaminitis or some derangement of the liver enzymes. And sometimes they can also have fever, they could have malaise, they could have some abdominal pain in the form of right upper quadrant pain, or there could be some mild hepatomegaly. Rarely some ascites can also occur. So now at this point, when they are having this fever, malaise, upper quadrant pain, so at this point, which is relatively early on post-transplant, say 1 to 6 months duration, so there are n number of things which will come into the differential diagnosis. So they could be your viral mediated pathologies, especially CMV. Then they could be your in the early phases, it could be your primary liver dysfunctions in the form of PRIs and SFS that we have discussed already. Then they could also be like viral pathologies, and there could be some sepsis condition. Infections can also lead to this kind of a picture. So there could be n number of things which will come on into this period, and they all are going to be differentiated from other pathologies, including the ACR. So what we need to do, so once the patient is having a derangement of LFTs, and this derangement of LFTs could be in the form of rise in bilirubin, it could be in the form of transaminitis where OTPT are going to be deranged, or it could also be in the form of increase in serum alkaline phosphatase. GGT is considered less because GGT elevation is normally seen early in the post-transplant period. So GGT, we are going to look less into this, and we are going to look at the other liver profiles, that is your OTPT and the alkaline phosphatase. Now, there is no specific pattern in which these are going to be deranged, and all the differentials that we had mentioned can come into the differential diagnosis of the ACR. So what a clinician is going to do? So what he is going to do a liver biopsy, because liver biopsy, if being done, is considered diagnostic for a for this acute cellular rejection. So they are going to differentiate this ACR from all the other pathologies, and for that, a liver biopsy is a must. Then we want to know whether it is a cell-mediated rejection or it is some other pathology that we have already discussed. So now this thing about the liver transplant rejection has originated from the BAM classification, which was originally given for the renal recipients, renal transplant pathologies, and it is nearly 25 to 30 years old, when in 1991, the first classification of BAM has come for the renal recipients. Then subsequently, it was extrapolated for other organs, and now we know there are every 5 years there is a new new modification that is being coming for the BAM classification of the renal transplant recipients. So when we talk of the histology of the acute cellular rejection, and that is the core area of discussion today. So when we talk of acute cellular rejection histology, there are basically a triad of things that we are going to look into. So we are more interested into the portal area. So here we shall be discussing about the portal area, and within the portal area, we shall be discussing three main pathologies. So we shall be discussing about the portal inflammation. Then we are going to look into the bile duct, and we are going to look at the bile ductal inflammation. And then we are going to look into the portal vein and not the hepatic artery. So we are not interested in hepatic artery of the portal tract. What we are interested in is basically the portal vein, and within the portal vein also, we are interested in the endothelial lining of the portal vein and the capillaries, and then we are going to see if there is any inflammation over there. So moving on to the first triad, the first component of the triad, and that is your portal inflammation. So we all know that portal in the normal liver, the portal inflammatory infiltrate is usually occasional 1 or 2 macrophages, and sometimes there could be some sprinkling of the lymphocytes there. But normally more than 5 lymphocytes, we generally don't expect to be seen in a portal tract. So when we are seeing an increased number of inflammatory infiltrate, and this is little subjective because when we have seen many liver, then you get to know that yes, there is a little elevation in the portal inflammation, and that we are going to find. Now this inflammation, if it is increased, we are going to look at the component of the inflammatory infiltrate. That is, what kind of cells are present within the portal inflammation. So whether these are lymphocytes, and as we said that these are basically the T cell mediated lymphocytes. So these are CD4 and CD8 positive T cells. So whether the component is made up of lymphocytes, eosinophils, neutrophils, macrophages, and there could also be some lymphoblasts which are seen within the infiltrate. So when we talk of rejection infiltrate, we are actually talking of a mixed component of infiltrate, which is in the form of dominantly lymphocytes, and there is also a fair proportion of eosinophils, neutrophils, macrophages, and some blast cells. Now, these blast cells, they are different from the lymphocyte because they are relatively larger in size as opposed to the normal lymphocytes which are seen in the infiltrate. So normally the rejection infiltrate is usually mixed in nature, which are with a component of all of these. Now, when we talk of these infiltrates, so as I said, there could be some eosinophils also within the infiltrate. And when we see eosinophils elsewhere in the liver, the first differential that comes to our mind is this a drug-induced liver injury? So we have to be very careful when we look at this infiltrate, what is the component where it is present, to differentiate them from the drug-induced liver injury from actually the rejection infiltrate. And if we see neutrophils, we need to differentiate them from the biliary pathologies. And then blasts are relatively specific for portal inflammation of rejection infiltrate. They are rarely seen in other pathologies. So now let's go back and look at some of the normal portal tract and how are you going to differentiate from a rejection infiltrate. So this is a normal portal tract. And as I said, you could see occasional lymphocytes, 1 or 2. Here and there per hyperfield, you generally see not more than 4 to 5 lymphocytes. So that is in the normal portal tract. There could be some sprinkling of the inflammatory cells, but they are generally lymphocytes. You fail to see a component of like mixed inflammation as we see for the T cell mediated rejection. So we would find a hepatic artery. There could be 1 or 2 bile ducts, and this is the portal vein. So in a normal portal tract, there is no ductal inflammation, there is no endothelial inflammation, though there could be some lymphocytes. So now you need to differentiate this normal lymphocytic sprinkling again from a mild rejection infiltrate, which is at a very borderline category. So this has to be looked into in the entire preview to say that this is actually a mild infiltrate or this is just the normal finding of the liver, donor liver. So now in the recent, previously it was called as acute cellular rejection. And now in the recent BAM, the terminology has changed and we call it as a T-cell mediated rejection. Now, when we talk of this T-cell mediated rejection, so as I said previously, you are going to see a mixture of infiltrate, which could be like there could be some eosinophils, some of these are lymphocytes, there could be some polymorphs as well, and then there could be some macrophages and also some blast cells. So cells which are larger in size, we would consider them to be little enlarged, and there could be some blast cells also. Now, in addition to this rejection infiltrate, there could be the infiltrate could largely be confined to the portal area. So we'll come to the grading of this infiltrate later on. So first we are going to look at most of the portal areas and we are going to see that what kind of infiltrate is there, and if the infiltrate is present, how much is the quantification of the infiltrate, whether it is mild, moderate or severe, or it is confined to just the portal area. So here, as we can see that in this field, we are finding a mixed type of infiltrate which is present and occupying the portal area. So these are again two another portal tracts from the rejection area. And as we can see here also, that infiltrate is like mild. Here again, we could find that there is mild increase in the infiltrate. So we do have some lymphocytes, we have some occasional eosinophils here. So this is the mild rejection infiltrate in both the images. Now, the infiltrate can go from mild to moderate. So there is like some more clustering aggregation of the lymphocytes and mixed cell. So here we have got some more than mild degree of infiltrate, which is moderate in nature. And at times the infiltrate could be very severe and sometimes it can also spill over into the liver parenchyma. So we could have different grades of inflammatory infiltrate into the liver cell. Now, as we move from mild, moderate to severe, the amount of mixed infiltrate would be same, though in the severe infiltrate, the lymphocytes are going to be proportionately more as compared to the other cells which are being seen there. So that was about the first component, and that was the portal inflammatory infiltrate. Now, moving on to the second component, and that is your ductal damage. So once we have identified the infiltrate, we are going to see whether this infiltrate is causing any injury to the duct. And since there is an injury to the duct, we find that there is mild elevation of alkaline phosphatase also when we see cases of rejection. So as I previously said, the GGT is going to be of less importance here. And by seeing an elevation in alkaline phosphatase, we are not going to jump to the conclusion that this is a cholestatic pathology which is occurring in the liver, or this is going to be a biliary damage, because you could see some mild elevation of alkaline phosphatase, and that is because of damage to the bile duct epithelium that we are finding here. Now, how does a bile duct damage is going to be? You're going to identify that damage in the liver cell. So first is you are going to find the presence of intraepithelial lymphocytes. So as we see for the duodenal biopsy in cases of celiac disease, similarly in the bile duct epithelium, we are going to see and look for the presence of these intraepithelial lymphocytes. So we are going to find, and within the epithelial cells which are relatively vesicular, we are going to see for the darkly stained hyperchromatic nuclei, which are lymphocytes, and we are going to find whether these lymphocytes are infiltrating into the ductal epithelial cells. If you are having problem in counting the number of epithelial cells or looking at the epithelial cells, you can go for a PS stain, which is going to delineate your basement membrane beautifully, and then you can come back and count the number of lymphocytes within the ductal epithelium. Now, once these cells are damaged by the lymphocytes, so what is going to happen? Their cytoplasm, which is like little amphiphilic in nature, this cytoplasm is going to become eosinophilic. And now the cells, instead of like amphiphilic appearance, they are now going to assume a eosinophilic cell change of the epithelial cells. So there is more eosinophilia in the cytoplasm of the ductal epithelial cells. So when we see eosinophilia, we know that there is some degree of damage which is occurring in the epithelial cells of the bile duct. Then next, you are going to look for the cytoplasmic changes, which could be in the form of vacuolar injury to the cytoplasm, wherein you are going to find cytoplasmic vacuolization, cytoplasmic clearing can be there. And lately, in the later stages, the nucleus will get an apoptotic change, and nucleus will be ejected out, will be removed from the cell. and then you would see a loss of nuclei from the epithelial cells. So all these changes in toto are going to be counted as the ductal damage. And once the most of the ducts are going to show you degenerative changes, that means from milder degree of damage, you are moving towards the severe degree of damage. So the next thing that is going to come is your endothelial damage. And likewise, as we mentioned for the ductal cells, here we are going to look for the presence of lymphocytes in the subendothelial region. So what we are going to see, we are going to find a vessel wall, and we know that the normal vessel wall is lined by the endothelial cell. So what we would found in the rejection infiltrate, that the lymphocytes which have come into the portal tract, they would now trickle and they would now seep and sit beneath the endothelial cells of the portal vein. So we would see the seeding of the lymphocytes in the subendothelial location. Then we could also see, because of this lymphocytic infiltration in the subendothelial location, we are going to find endothelial cell injury. And what are the features that will tell you that the endothelial cells are injured? So you will see some swelling of the endothelial cell nuclei. So as compared to the adjacent nuclei, there would be some enlargement of the endothelial cell nuclei. There could be upliftment. They will be detached from the basement membrane, and they would now move towards the lumen. So as if they are walking towards the moon, so they would leave the attachment to the basement membrane, and they would now come inside the lumen. And later on, there is complete detachment of the endothelial nuclei, and there is loss of nuclei would be seen from the vessel wall. So all these changes together are going to be counted as the endothelial damage. So we talked of ductulitis. So this is what a ductulitis is going to look like. So we have got a liver parenchyma. This is your portal parenchymal interface here. And in the portal tract, we could see that there is a mixed infiltrate, some use dominance of lymphocytes, and there could be some polymorphs, occasional plasma cells, but plasma cells are generally a less dominant cell in the rejection infiltrate. Now here we could see that there is a bile duct, and these are the vesicular nuclei of the normal ductal epithelium. So a normal ductal epithelium would have the enlarged nuclei. It is more open chromatin that we see here, similar to what we find in the hepatocyte nuclei. So similar to the vesicular nuclei, here also we are finding that the nuclei are enlarged and vesicular. Now, within this ductal epithelium, there are few cells which are now impinging and coming and like hitting the nuclei of the epithelial cell. So there is some endothelial cell, some lymphocytic infiltration into the ductal epithelium. So when we find a picture like this, then in addition to that portal infiltrate, we are going to say that this is basically the ductal inflammation, and there is also some lymphocytic damage which is occurring to the ductal epithelium. So this again is a bile duct, and here if you look carefully, now in this bile duct, we are finding that some of the this is the lymphocytic nuclei. These are the nuclei, and at times when these nuclei are damaged, they will become apoptotic, and therein it will become difficult to differentiate them from the lymphocytes. So you need to differentiate these cells from the lymphocytic infiltration that is happening. And then in addition to these like hypochromatic nuclei, we are finding that there is some lymphocytic infiltrate into the epithelial cells. And then we are also going to look for the cytoplasmic changes, which is in the form of cytoplasmic vacuolization, like or clearing, as we could see here. Now, there are some cells where the nuclei is not evident. So there is some loss of nuclei from some of the cells. There is some cytoplasmic vacuolization, and all these changes together are going to tell you that there is some ductal injury which is happening secondary to the infiltrate which is seen in the portal area. So this again is a greater degree of ductal damage. So initially there will be few ducts which are showing it, and then as we move on, we would find that more and more ducts are going to show you these changes. So you're finding them in most of the tracts that we are going to see. Now, again, for this point, we need to have very good sections to identify these cytoplasmic vacuolization, these changes of the nuclei, because if the sections are not very good and you're not looking at them carefully, you can also see these changes in a normal bile duct. So you need to be very sure that these are actually the ductulitis changes that are happening because of rejection infiltrate, or these are because of your abnormal sectioning, or these are just the artifacts which are occurring in the liver. So now there is another thing that we say in the bile ductal epithelium, and that these are the degenerative changes. At times, the degenerative changes can be so florid that they would look as if there is some atypia that is going on within the bile ductal epithelium. So if you are finding abnormally dark nuclei, you should not think that this is basically a dysplastic nuclei, because if the bile ducts are damaged to a greater extent, we call these as the degenerative changes, and these ducts look very atypical. And then if they are occurring in most of the tracts, or there is disruption of the duct lumen, then you know that these are graver forms of ductulitis, which is occurring as a result of this rejection infiltrate. So this again is a liver tissue, and here we are finding a moderate degree of rejection with degenerative changes of the ductal tissue. So here again we are finding a duct, and in this duct it is difficult to identify the duct lumen. So we are finding a portal vein here. We are finding some venous profile. These are the venous wall. There is a mixed inflammatory infiltrate, and here we have got a bile duct. Sometimes when the ductal lumen is disrupted, it is difficult to identify the duct within the portal tract. So therein you need to differentiate them from the inflammatory infiltrate which is occurring in the liver, in the portal tract, and you need to be really sure that this is the thing that I'm looking at is actually a bile duct or it is something else. So what you need to do is you can either get a PS stain done to look for the basement membrane, but if the duct is completely disrupted, it would become difficult. So here we have got a ductal profile where the lumen is disrupted. There is a lot of damage to the cytoplasm of these bile duct epithelial cells, and also to the nuclei of these ductal areas. So this is a disrupted duct lumen. Now, moving on to the next thing that can occur within the portal tract, and that is your endothelitis. Now, as I said, endothelitis is basically a normal vein is going to look like somewhat like this. So here we have got a normal vein where the endothelial cells are quiet. They are quietly sitting on the basement membrane, on this vessel wall. So there is no disruption of no anxiety within the endothelial cells. They are quietly coming and sitting on the basement membrane. But if you look here there is no lymphocytic infiltration of the subendothelial region. Now, if we compare this area with this area, so here we are finding that there is lot of these lymphocytes which are present and sitting beneath the endothelial cells. So this is called as subendothelial lymphocytic infiltration. And again, this needs to be differentiated from the portal infiltrate which is coming into the portal stroma. And by seeing the infiltrate in the stroma, you should not call it as an endothelitis, because endothelitis is when you see the damage to the vessel wall. So this will be accompanied by the endothelial cell damage, and that could be in the form of swelling of the endothelial cell, enlargement of these endothelial cells, and later on the upliftment and loss of the endothelial nucleus. So this is how the cells are going to come and sit beneath the endothelial cells, and this is also known as a string of pearl appearance, similar to what we see the pearls in a garland. Like so likewise, we would see the lymphocytes coming and sitting beneath the endothelial cells. So this is what is known as endothelitis. It can occur in few or most of the vessel wall. So now moving on to what are the triad of these acute cellular rejection infiltrate that can be seen. And we have discussed about the ACR. What are the findings? We are going to see portal inflammation. We are going to see bile duct inflammation, and we are going to see the venous endothelial inflammation. Now, again, to remind, we are not counting hepatic artery here. So we are not interested in the hepatic artery inflammation or the arterial changes. We are only interested into the portal vein profile, central vein profile. We are interested into the capillaries and the periportal like inlet and outlet venues. Those we are interested in. So now for each of these, there is a scoring system that has been proposed in the BAMS meeting. And I could understand why they are doing this meeting in BAM, because that is one of the most beautiful national park, which is a mountain national park. So every 5 years they conduct a meeting, and there they give new changes into the what is already proposed as for the liver transplant pathology. So now there are, as we said, there are 3 things. That is your portal inflammation. We have got bile duct damage and venous endothelial inflammation. Now for each of these things, we have got increased grades of severity, and then they are graded on a score of 1 to 3. So portal inflammation mild in some of the tract, moderate in most of the tracts, and then we have got a spillover into the adjacent parenchyma. So once the infiltrate is confined to the portal area, it is 1 and 2. And when the infiltrate will go and move to the, it will like lose the Lakshman Rekha, and now it will go and spill over into the adjacent parenchyma. That is your gravest part of portal inflammation, graded and given a score of 3. Now, in the bile ductal inflammation, again, we have got few ducts which are infiltrated. Then we have got most of the ducts. And then if you are finding most of the ducts showing degenerative changes or there is luminal disruption of the duct, then we call it as a grade 3 of the bile duct damage. So if it is found in few of the tracts or it is found in most of the tracts. Now, when we say few or most of the tracts, so we are talking of a biopsy which is having like adequate size biopsy. So it is having an ideal biopsy should be 11 to 15 portal tracts should be present. And then the third component, that is venous endothelial inflammation. Now, in this venous endothelial inflammation, as I already said, we are talking about the portal as well as the hepatic venule. So we are also talking about the central vein and the inlet venules here. And this inflammation could be in some of the portal veins or it could be in most of the portal veins. Or then this inflammation could be into the central veins wherein it has started damaging the liver cells. So once it had started damaging the liver cells, that is considered the gravest part of venous endothelial inflammation. And you will learn more about it when the late acute cellular rejection will be discussed. And therefore, it is given a grade of 3. So each component we have got a grade of 3. And then we are getting a total score of 9. So a total REI score is given out of 9. So we will get a score of like 3, 4, 5, depending on what is the total score of these 3 components. So when we do a scoring system for these, we get a score from 0 to 9. And based on what score we are getting, we are going to call it as indeterminate when only 1 or 2 score is there. So when you're finding only some little lymphocytic inflammation in the portal tract, there is not much of ductal or endothelial inflammation. So it could be a indeterminate score where the score is only 1 or 2. So in indeterminate score, it could still be a rejection infiltrate or it could be other differentials. As we had already mentioned, it could be a part of infective pathology or drug-induced liver injury, or it could be a part of your PRIs or like early graft dysfunction pathologies. Then if you are getting an infiltrate of 3 to 4, it's considered as a mild rejection infiltrate. And generally in mild, no treatment is given. So most of the centers, they would not start any therapy if there is mild rejection infiltrate. But if you are getting a rejection infiltrate of over 5, so in these cases, the patient is empirically treated. He is given some steroid therapy here. So steroids are started because at this point of time, they think that this infiltrate can damage the liver parenchyma. And if there is a graver form of rejection, it can go into the late acute rejection. It can progress into a chronic rejection. So out of those 20 to 30% of the ACRs, which we see in post-transplant settings, which are clinically significant, out of those, say 8 to 10% are going to progress into chronic rejections. And these are the ones which are either not treated or which could not be treated because of some secondary complications. So these are the ones which can later on go and progress into a chronic rejection. So that is, we talked about the acute cellular rejection. We talked about the histological features of rejection. And then we talked about the different grades of rejection. So now coming on to the course of this ACR. So this ACR, this could be like early cases, they are steroid responsive. So as I said, if we are having an early cases of acute cellular rejection, so then they could be, you can give a steroid therapy and they can respond to that. The severe cases, especially the severe ones, if there is an LAR of 7 to 9, then RAI of 7 to 9, then those cases may be steroid resistant. So if you are getting a severe rejection, you give steroid, they may or may not respond to steroid, and then you would require a thymoglobulin, thymoglobulin may be required, anti-TG could be given for them to be responsive. And then even if they do not respond to these therapy, they can progress and they could be refractory, and then they can progress to a chronic rejection. So you could have varied course of ACR based on what stage you are getting them treated. So that's why it is very important to get the tissue biopsy and to get a biopsy proven ACR. And once they are like proven by a biopsy, you can start your therapy and avoid getting into the course of this chronic rejection. So this was our paper that we had published in the IGOT again. That's retrospective post-transplant liver biopsies, and this you all can go through. So with this, I conclude this session here, and I hope this was little useful to you all. And if there are any questions, we can take them up tomorrow in the live session. So thank you so much. Thank you for your patient hearing.